Can everyone see your screen with the slides on it? Today's topic is going to be about children and grief.
Can someone just chat us to say, yes, I can see it, or
someone Ben just wrote. Thanks, Ben.
Thank you.
So let's make it bigger.
Beginning. Oh,
sorry. Great.
Well, hello, everyone. Good afternoon. And it's morning here in New York. And I'm Peggy Murphy. I'm an outpatient palliative care social worker here at Weill Cornell New York Presbyterian Hospital. And alongside me, I have Kim Hong, who's another palliative care social worker in our inpatient service. And as always, Dr. Randy Diamond, one of our attending physicians, is present too. And we look forward to spending some time speaking with you this morning about children and grief.
And we apologize. I think today is just audio. We weren't able to get our video started, but we are here, and please, as always, we welcome you to interact with us via chat or the Q&A.
So, the very first question we really always want to ask, and this is really important today since we're not able to show you our faces, is who are you in the audience? If you wouldn't mind putting in the chat who you are, where you work, in what capacity.
Sorry, I think the screen sharing was just paused.
Sorry, everyone. I think the rain in New York has gotten into our computer. We're resharing.
Okay, I think now you all can see.
Great. So if you don't mind putting in the chat just where you work and what your profession is. Are you a social worker, a nurse, a health worker, a physician, a chaplain?
Thank you. We're seeing all the responses. We have people from Uganda, Zimbabwe, Ghana, and we have residents and someone from a campus ministry.
Wonderful. Okay. So we created this slide. UNICEF estimates that nearly 140 million children under the age of 18 have experienced the death of one or both their parents. And as you can see, that was cited in 2017. The numbers certainly may be higher with increased wars and COVID, but that's a pretty significant number of children managing loss. And I always like to start off talking about the work that we all do is helping people with the human experience. So this quote is by Fred Rogers, who is very well known in the United States with his work with children on television and helping children and families cope with difficult topics. And he always says, whatever is human is mentionable, and whatever is mentionable is manageable. And if we could keep that thought in front of us today. The goal in front of us, whenever we talk about helping children with illness and death, is helping children stay on developmental track, making sure that they make their milestones, and working with them and helping them sets the stage for trust and coping throughout their lives. Illness in the family ages the family. And I don't know if that's occurred to anyone out there who's working with or seeing children who are grieving. But when an illness happens to a family, children tend to be a little bit more mature in terms of what they're exposed to. And this is, of course, situational, it's cultural. And let me also say that any work we do with children is always in the context of their family system. You work with a child, you work with the family. And we'll talk a little bit more about that as we go along this morning and talk a little bit about interventions too. So we look at families in their respective life cycles. And what we mean by that is, what is the age of the family and what are they working on? And what I'm referencing is the work of Erik Erikson. Erik Erikson had 8 stages of psychosocial development. And it's really important when you're working with families to have a sense of where they're at, and also to have an understanding of children developmentally too. And I'm going to talk about that in a second as well. And why is it important to understand developmental stages for children and adults? Quite honestly, we need to be able to tailor information and interventions in a way that children are able to understand. And we need to know where a family is located in their life cycle to understand what's in front of them and what they need to accomplish. And I said this earlier, but I do think it bears repeating that all of our work is within the family system. So that's whoever's important to the child. That could be parents, it could be guardians, could be aunts, uncles, grandparents, good family friends, whoever is caring for and involved with the child is part of the family system. And siblings too, of course. So I want to start off talking very briefly about Jean Piaget, who was a Swiss psychologist and studied children, came up with the theory of cognitive development, which focused on the intellectual development of children. And why this is so key to understand is we need to know where a child is at in terms of understanding things like the permanency of death. So he focused on cognitive changes from infancy through adulthood. And what he's noted for with the stages is that children progress through 4 distinct stages. The child has to develop a mental world and a thinking structure. The sensory motor stage, which is the first one, is infancy through 2 years of age. And those children are learning about object permanence. So for those of you who don't remember object permanence, it's something is in front of you and disappears. So the classic example of this is peekaboo. If you play peekaboo with a little child and you cover their eyes, they think you've disappeared. And then when you move the hand away from their face, they see that the parent or the person is still present. Children explore the world from inside out. The second stage is pre-operational thinking. So that's ages 2 to 7, and that's being able to think in symbolic thought. The concrete operational stage, which is 7 to 11, is logical thought. And that's where children are starting to understand more abstract concepts. By age 11, which is the formal operational stage, and which goes from 11 through adulthood, children are able to think in concepts. They're able to understand that death is permanent, that if someone dies, they are not coming back. And then there's Erik Erikson's 8 stages of development. And what's important with these stages is that they balance the psychological needs of the person versus the needs of society. And either there's a positive outcome or a not so positive outcome. So the first stage, which is trust versus mistrust, a child trusts that their basic needs will be met or they won't be met, depending upon how they're cared for by their parent or caregiver. For early childhood, ages 1 to 3, autonomy versus shame and doubt, children are developing independence and performing certain tasks. And what we typically think about is being able to feed yourself and toilet training. Ages 3 to 6, initiative versus guilt. Children are able to initiate certain activities and may develop guilt if they're not successful with those activities. Ages 7 to 11, inferior industry versus inferiority. Children developing mastery and competency over their abilities, learning different skills, an activity, a sport, perhaps doing well in a subject. Ages 12 to 18 is identity versus confusion. Children start to develop their own identity as an individual, their psychosexual identity, experimentation, trying on different roles. And then as we progress, there's intimacy versus isolation, which is early adulthood, ages 19 to 29. And that's where people start to establish intimate relationships with other people. Middle age, which is, it's interesting, the aging of the stages is a little bit dated, but it's ages 30 to 64. And it's generativity versus stagnation. So in this period in life, people are contributing to society and becoming more professional, establishing family relationships. And then the last stage is old age, and that's 64 or 65 and up. And it's integrity versus despair. And really the importance of this is talking about life review, talking about choices that were made, and what life has looked like in terms of decision-making. And again, you're saying to yourself, we're talking about children today. It's all connected, it's all relevant, especially the first 4 stages. But it's possible that you might be talking to a family that has a small child, but they're a young couple trying to establish themselves. And it's significant to understand where they're at. And then just very briefly to touch on attachment theory, John Bowlby, actually a psychiatrist who studied connections of parents and children during World War II, looked at how parents were connecting to their children. Mary Ainsworth and Mary Maines, who were his students, then studied that work and coined the 4 different stages of attachment. And really what they're looking at, if you look at the slide, they're looking at what the connections between caregivers and children look like. So if a child has a secure attachment, it means that they know they can trust their parents or their caregivers and their needs will be met. The other stages talk about difficulty in connecting. Does anyone have any questions so far? I always feel like it's important to give a little bit of a background and a context. Any thoughts about anything that we're sharing?
I asked that in the chat as well.
Okay.
If any of these theories are familiar to you, have you heard about it?
Yeah.
Have you used them in your practice?
Okay. Well, there'll be time to also circle back. Okay. So I just want to mention, I'm talking still about illness. Children who take on adult roles, there are some children who are expected to provide physical and emotional care for parents instead of having their own needs met. And this is a role reversal. And the term that we often use to talk about that is parentified. We see this in different settings in healthcare. There are so many different families and different configurations and different experiences of illness. And in some families, children are actually taking on more responsibilities because of the way the families are set up. It's just an observation, and it kind of links to what I was saying a little bit earlier about the fact that children in families where there's an illness tend to age a little bit. I'm going to talk a little bit about information in children because it's important and it's going to be relevant too when we're talking about death. And I think it's important to understand that in order for children to give children information, parents really need to be able to have integrated the information about their illness. What does that mean? That means that parents or caregivers need to understand the diagnosis. They need to understand the treatment plan. They need to understand how that's going to impact the children and impact themselves, and what their life is going to look like, how things may or may not change, who will take over certain responsibilities, what the family system is going to need to summon together in order to manage the illness. It's a tall order. It's overwhelming. I also believe that it sets the stage for a child's understanding of illness, but also when we're looking at end of life too and death. And having to give children information about a serious illness or death really challenges a lot of assumptions that people have about what childhood should look like. And I'm saying this, and I should have said this actually a few minutes ago. You know, anything that we're presenting today is a very specific Western American lens of working with children and families around illness and death. And it really needs to be understood that we understand that what we do here may not always apply in other settings. And we also know that there are children throughout the world who are facing all types of crises and trauma, irrespective of an illness. But what we're talking about with this very specific lens is a special thinking about children, that children should be protected from sad things, from things that are upsetting, from death. And we see that a lot here in America. There is definitely an idea of how children should live and be protected. And so when we're talking to families about either sharing an illness with a child or talking about death and dying, we're really kind of breaking into that assumption that people have. And that could be really painful. And sometimes you'll see resistance around it. And it's not unusual in our experience to meet families who the patient is coming to end of life and the child has no idea, or at least hasn't been told specifically. Helping children starts with information. And I'm going to say that any work that you do with a child, I said this a little earlier, you're working with the family and the family system. A lot of it's education and a lot of it's supporting families. And it's important to tell families that there are going to be many conversations and that the context is going to continue to change as a child becomes more mature. So a 2-year-old is not going to understand that mom or dad is not coming back, that death is permanent, but an 11-year-old will have a lot of questions. And I think that that's really challenging too, because when we're looking at grief in children, we're looking at a lifelong process of trying to come to terms with loss, because they'll keep experiencing it differently, as will the parent or the guardian or whoever is taking care of the child. We always, when we're talking about illness, we always say we use the correct term for the word, whatever the illness is. And we ask children if they've ever heard the name or the word before. And if so, what have they heard about it? And then we ask if we can give them some information. And we try to do that in an age-appropriate way, quite simply. And I'm shifting a little bit. I found this quote from Dr. Alan Wolfert, who's an expert on grief. And one of the things he talks about in understanding children in grief is that grief doesn't focus on one's ability to understand, but on the ability to feel. And the point of that is that anyone who feels grieves. So it doesn't matter how old the child is, the child can still be sad and not understand what's happening. When this slide, teaching and modeling Families are always teaching their children how to cope with hard times, loss, and crisis. How and if information is delivered to children teaches them. One of the things that we're always talking to families about is there are always opportunities to revisit information. But the goal, besides what I said earlier about helping children stay on developmental track, is to always let children know that they're safe, that there are adults they can turn to, that their needs will be addressed, and that we're in this together as a family, as a support system.
I know someone commented, and I just also wanted to bring up that I know we said this in our last few sessions, but the topics that we do here and the theories and the lessons and the case examples we bring, we also understand that they're from here in the United States in New York, and it's one lens. I know someone, I think Janet mentioned in the chat that death is a quote way of life in most African settings. So I asked, Janet, if you can tell us more about that in the chat, or how is that normalized in that culture? We would love to hear more about that, but thank you for bringing that up. It's very important.
Yeah. So in Janet saying that, I'm wondering what you're thinking about some of this information, and if it's anything that you use so far, and also if you're working in settings or you live in places where there is a lot of death, what you're seeing with families in terms of their ability to share information with their children, we'd be interested to know. And I echo what Kim said, and I had said it also a few minutes ago, that, we do have a very specific lens. We myself, Kim, Dr. Diamond, we do not know what it is to live in a war-torn space. So we're not going to actually understand some of the context. So anything you'd like to share with us, either if there's a way of unmuting, or if you want to share through the chat, we'd like to hear it. I think you have a lot to share that's really important. Okay. What I'm going to say here, what to say at a minimum to a child about illness and death. And this is illness, but it gets repeated when someone actually dies, is that you can't catch and usually in our setting, we're talking about cancer. And it's not addressing genetic illnesses. That's a separate issue. But generally, you can say to children, they're not going to catch whatever the illness is, that they didn't do anything to cause it. It doesn't matter how old the child is. And I mean, really from, I want to say 4 or 5 through adolescence, children often think that they had something to do with causing an illness. And it could be something as simple as being angry at a parent and then learning that they are sick. We always want to emphasize that it's okay to have many feelings about this. And again, that someone will always take care of you. And when we say that to children, we really need to be able to point out who those people are. So we're not going to just make the statement and walk away from it. We're going to name the helpers or the caregivers. So going to talk a little bit more formally about grief in children, shifting into that. Parents and important adults in children's lives can be really helpful in terms of helping children understand what grief means. It means very powerful feelings, missing an important person. It's really important as adults, and when you're talking to families, is that grief looks really different for children than it does for adults. Adults have a capacity to sit with sadness for very long stretches of time. Children may be sad for a moment and then distracted in an activity and not look upset. And that can be distressing for adults sometimes. It doesn't mean a child isn't grieving. Children work out grief in different ways. And children need a social network. I think, and I'm going to talk about this a little bit when we talk about interventions, groups are really helpful if the children in the groups have similar losses, because it's a very lonely experience to lose an important person like a parent or a sibling. And I can tell you from past experience with running groups that often the first statement when a child walks into a group is, oh, wow, there are other people like me. It's really important to have that validated. Say something?
No, that's great, Peggy. I know there a Q&A just came up. Alice wrote, how do you tell children that you have HIV/AIDS when there's stigma attached to it? Thinking,
Wow.
it's really hard, and it's so different, but I almost think about even here in our settings, in our lens, when children find out their loved one or their parent has cancer, since there's a lot of stigma attached to this here as well, in the States. But I think a lot of times I talk with parents or their loved ones, or even children, about them not blaming each other, right? I think there's a lot of children are saying, like, did I have to do something, or is something my fault? Also, I think going back to some of the theories that Peggy was discussing, that feeling of what happens next, like what's going to happen to me in the future. But that is really difficult. Do you have any thoughts?
Well, I guess my question is, when you say it's a stigma, is that an adult perception, or are children is it a stigma that you think children are experiencing too, or is this more in the adult world? I'd be interested to know about that, because, and I don't know if you're going to think that this applies, but when we talk to parents about giving information, sometimes parents are really worried about, and I'm going to use the example again of cancer, of their own concerns about cancer. Sometimes children haven't actually heard about some of the things, some of the illnesses that we're worried about or we know about. So I guess it's always important to start where the child is at and to ask them what they know about it. Have they heard the term? That's important to understand. If they tell you they haven't heard it, then you can give very basic information depending upon the age of the child. You can name the illness, you can name that it's HIV/AIDS, and you can explain whatever the treatment plan is, and how the parent is going to manage it, and who's going to be there to support the child. I think I would start with that. Can you respond to us to let us know if that answer is helpful? And also anyone else who's on the webinar today, if you would feel free to respond also how you would handle that, because you might have a better response.
But thank you. That's a great question.
Yeah. I think that I said this a little bit earlier, but to kind of emphasize this point with children in grief, that children continue to understand the death of someone important to them differently as they move through different developmental phases in their lives. And I think that this is the ultimate challenge and the enormity of helping children and families when an important person has died, that we know that the family is dealing with the moment, right? They're trying to figure out how to help the child where they're at in the moment. But we know that there'll be different developmental phases that the child goes through as they move through childhood and adolescence and into early adulthood. There are different milestones, perhaps graduating from school, perhaps getting married, perhaps, becoming an independent person that the person who died won't be present for, and that the child will have to process and continue to understand and figure out also how to hold on to the person who died, how to continue to have some kind of connection with them. I know somebody whose husband was killed, actually, and who every year they celebrate the holiday of Christmas. They put together a regular Christmas tree, and then they put together Dad's tree. and dad's tree is decorated with special items and pictures that are all about dad. And it's a way that this family remembers dad, acknowledges dad, and he's part of the holiday. And I think every family is challenged in some way with keeping that special person connected, and also trying to understand what life continues to be without that person. So we always ask this question, and I think we've said this, Kim and I are social workers. So in looking at people, we're always looking at people within the context of their lives and their world and their family systems, person in their situation. So one of the things it's really important to name is, who are the important people in the child's life? And they can be, and we label them helpers of children. They're anyone from parents to grandparents to siblings to aunts, uncles, cousins, teachers, doctors, nurses, health workers, people in the village, family, friends, athletic coaches, faith leaders. It's important to know who they are. It's important to name them for children and point them out as other people for support and people that they can go to for comfort if that's the case. And also to involve those people, to let them know what's happening, so that everyone can kind of keep an eye and support the children. And as I said, one of it, not to sound trite, but I think this is really true. It does take a village. Raising a child takes a lot of people and a lot of energy. So if we can help the children name the people who care about them and who they can go to when they're scared, sad, have questions, it's really important. And it's another way of grounding children and saying, if for some reason I'm not the person, you can go to this person. We all love and care about you. So I'm going to shift a little bit, because when there's a death in the family, and this also does apply to illness too, but people are always worried about, how will I know if my child is struggling, right? So especially for younger children who may not have language, we always look at behaviors. So I always talk to people about, well, what are the worrisome behaviors, right? So we always look at people around change and function. So for children who typically sleep through the night and do not have sleep disturbances, so all of a sudden have insomnia or nightmares, or children who are hyposomnic, children who are sleeping way too much, and they're usually not great sleepers. Changes in moods, changes in behaviors. A child who's really talkative becomes real quiet, or vice versa. Changes in eating habits, too little, too much. Changes in grades. Changes in grades that's an important piece to pay attention to. And we often skew that to say, well, if you see a grade dropping, that's something to be concerned with. I would say also the child who puts a lot of emphasis on getting straight A's, being the perfect student, that needs to be paid attention to as well. Changes in toileting, especially in younger children who had mastery over toilet training, now all of a sudden are regressing, wetting the bed, having accidents. Changes in the quality of friendships with children who seem aggressive, angry, taking their physical aggression out on friends, on siblings. Somatic changes. So a child who's complaining of a lot of belly aches, a lot of stomach aches, a lot of headaches, a child who's becoming really clingy, and certainly any child who is talking about suicide, who's threatening to hurt themselves. It's really important in looking at worrisome behaviors to look at the intensity of them too, and whether or not they're interrupting functioning. So what do we do about worrisome behaviors, which is, I think, what we think about when we think about our concerns about grieving children. So some of the things we can do is, if there's a local support group, I would really encourage in your work with families to to try to connect children, because we socialize children in groups, and it's very, very helpful for children to understand that they're not alone and to have peers to connect with. Pediatricians or medical providers, you should reach out to those people if they're available. Ensuring, as I said earlier, that the adults in the child's life are watching out for the child. Ensuring consistency for routines, certainly. One of the things that children count on in terms of understanding safety in the world is making sure that the world makes sense. And who helps children with that sense of senseness and groundness are their caregivers. So if you are somebody, when you're talking to families, if the parent or caregiver is someone who typically would enforce bedtime, and now all of a sudden there's a death in the family and we're not really even paying attention to when the child is going to bed, that's really scary and feels unmoored. And it's really important to take a step back, and you can share this with families, to really pay attention to, can we get back on a consistent schedule as much as possible for the kids, in terms of eating and sleeping and making sure they're getting to school. I was talking earlier about concretely listing, who the helpers are. And if a mom or a dad has died, who will do the things that they did? So who does the mommy things? Who does the daddy things? And it's really important to name those things, that those activities or tasks are going to still take place. And this is who's going to help us with those. And they're going to happen for you. And then the other thing that's really important to emphasize, that's not always spoken, is the concern about the surviving parent or caregiver and their health. And it's always important to be truthful about this, but to really say, actually, let me take a step back. If you're talking to someone who's a caregiver or a surviving parent, if you can encourage them to make sure they're taking care of their health, that's really important. And also to share that with the child, that, I'm taking care of my health, that I'm doing everything that I'm supposed to do, checkups, medication, whatever it is, because, I'm here to take care of you. So some of the interventions with children who are grieving, I've talked about this psychosocial support a lot in terms of education, because I really think it's key and it's a great background and basis. I was talking about support groups. I have experienced them as being truly invaluable for children. Those connections are so helpful. And depending upon where you live, and again, I'm going to say this, in an American Western view, where death may not be as prevalent for children, the isolation of being a child who lost a parent or a sibling or a primary caregiver is really profound. So we try to always connect children with other children who are in the same age range, to help process this. And those support groups are often really activity driven. Children may not have language skills. They also, when we work with children, we tend not to necessarily discuss some of the feelings head on, but we do it through activity. And I'll get into that in a minute. Family therapy is very important. If a family is struggling, sometimes the surviving family members need to get together with their child and process grief together. One-on-one counseling is very important if a child's had a lot of trauma or is just not fitting in it with a group. And some of the work is legacy work. So that's really looking at the person who died and what was important about that person. In the hospital, when we have a patient die, we have a wonderful team of people that I'm going to talk about in a couple minutes called Child Life Specialists. And they do specific legacy work, such as making handprints of the person who's dying for the child to hold on to, or recording voices so children can hold on to that. So there's something concrete to hold from the person who was dying, if that's even possible. Some of the other things we do with children is we make memory boxes, and you can take a cardboard box or even a wooden box and decorate it with paint or markers, and you can put special items in there. The child can decide what should go in the box that's really special about the person who died. Play therapy is certainly important, and that often happens in one-on-one work. A lot of work through dolls, through storytelling, a lot of artwork with children, drawing feelings, drawing pictures about the family, drawing pictures about life, how life looks. There are a number of board games that have come out. Good Grief is one that helps talk to children about their feelings around grief. And then there are also picture books that are helpful too. Or you can even sit with children if you have some paper and some crayons and make a storybook together about this experience and how the child is feeling. So I want to talk a little bit about Nancy Boyd Webb, who was a doctor of social work, who also did a lot of work in the United States around death in children and play therapy. And she came up with this tripartite, which is a 3-part assessment of the bereaved child. And I know it's not the best slide. I was actually trying to take a picture of it. What I want you to take from it is there are 3 categories that we're looking at when we're looking at children. So the individual factors, so we were talking about that earlier, the age, the developmental stage, the child's understanding or cognitive level, their temperamental characteristics, whether they're easy to anger, whether they laugh a lot, whether their child is a typically happy child or kind of not so happy, a little moody, past coping adjustment, home, school, their peers, whether or not there's a psychiatric diagnosis, the medical history, and their past experience with death or loss. So those are individual specific factors to the child. Then there are death-related factors, which are important to understand. So the type of death, was it anticipated or sudden? In the setting that we work here at Cornell, the deaths may seem sudden, but we often know they're coming because the person has a serious illness. But the timeliness of death is important. Was it preventable? The degree of pain, the presence of violence or trauma. The person mentioned earlier the element of stigma. And I should say something. You were asking specifically about how to give information, but I'm thinking about stigma also in terms of support. And when someone dies in a way that people are not going to talk about and they feel there's shame attached to it, then there might not be as much support for the surviving people. And that's really important to pay attention to. And those are disenfranchised losses. Contact with the person who died. Was the child present at the death? Did they view the body? Did they attend a ceremony? Visit the grave? Did they get to say goodbye? What was the relationship quality like? Their reactions? And then there's the family section, which talks about who's in the nuclear family, the family's grief reactions, because the child has a reaction, the family has a reaction, they have a reaction together. The extended family reactions and support, school's involvement, recognition of the bereavement, peers, friends, responses to bereavement, whether there's a connection to a house of worship or a religious affiliation, beliefs about death as a family. Do they believe in an afterlife? Are there certain rituals connected? Typical views about death, and also the extent of child inclusion, which is really important. Is the child connected to the experience, or are they hearing about it? And I'm gonna jump to this and then we'll go back to what we were just talking about. But, you know, since we are palliative social workers and we're in a palliative program, our focus is always on alleviating suffering. So it's really important when there's an illness in the family, and then if someone dies, that children know that something is wrong, right? They're going to substitute any non-information or misinformation with their own ideas, and that creates suffering. Not providing age-appropriate information adds to suffering for children. Having information is actually empowering, and information actually sets the stage for helping model, this is how our family manages crisis, which is why even when we're worried about stigma, it's important to help name what's going on. And I said this earlier, that young children do not understand abstract concepts such as death permanence. And children are not able to sit with sadness for long periods of time. But as we were saying earlier, as children age, so does their understanding about loss. They'll experience the death in different ways as they grow developmentally. I want to talk to you actually about a case, a patient that I had worked with for a couple of years named Jay. I worked at an agency at one point that counseled people with cancer and also worked with children and families who were managing grief when someone died. And this little boy came to me. His dad had died actually from cancer and AIDS. And Jay also had AIDS, HIV/AIDS himself, which was not something that we dealt with so much because he had a social worker who was working with him specifically about his own illness. But he was living with a guardian named Lola who brought him to my office to meet with me. And his mother, I should mention, was not in the picture, not in his life. So Jay was 5, and we would work together with, I would see him and I would see Lola, and we would work in either the playroom in the agency, or we would go upstairs to this big conference space. We had this massive room where we would hold meetings. And when it didn't have tables and chairs, it was just this wide open space. And we've said a number of times to you, we're in New York City, so space is a luxury here. So when Jay would come to visit, he sometimes wanted to come up to the conference room where he could run around. So one day, Jay said to me, "Oh my God, Peggy, there's a fire." And I said, "Jay, what are you talking about?" And he said, "Look." And he ran around the conference room from one end to the other, making a hose with his hands and putting out the fire. And he kept running and kept getting more and more excited about the fire. And he said, "We've got to put it out." And I said, "You know, Lola and I are here to help you. Can we help you put the fire out too?" And he said, "Yes." So we would run with him from one corner of the room to the other and help him put the fire out. And we made, you can't see me, unfortunately, but I'm making a hose. I'm using my hands as a hose. Kim's seeing it anyway. And so we would aim our hoses at the fire, and Jay would continue to direct us as to where the fire was and where to aim our hoses. He became our supervisor, if you will. So after that, after we did that, and I would say it lasted about 30 minutes of fire putting out, we sat together and had a snack. And the three of us talked about fire and who his helpers are. The next time he came to see me, we started to make some of this, what would you call it? Some of the things that you associate with a fireman. So he'd gone to a local firehouse with his school, and he had a plastic red hat. That's what firemen wear here in New York at any rate. So he wore the plastic red hat of the fireman, and we drew and made like pretend hoses out of construction paper and oak tag, which is a thick paper. And throughout our work together, at different times, we would make different symbols related to the fire. Jay also really liked the playroom and gravitated towards, we had a dollhouse. We had this wooden dollhouse that had figures that were multicultural and different sizes and shapes. So they represented children, they represented adults. And Jay would do a lot of resurrecting of Dad. And if you know what I mean by resurrecting, so Jay would say, Dad's dead. And he would take the doll and throw him like onto the bed. And then he'd say, oh, just kidding, Dad's alive. And he would do this periodically. And we would talk a little bit about that, like how he felt when Dad had died. We would talk about the feelings in that moment, I should say. He did that for probably about 6 months on and off in our work together. We also did a lot of feeling drawings. So Jay wasn't always able to tell me what he was feeling, but he could draw angry faces. He actually also drew a lot of fire themed pictures too, to indicate when he was really feeling strongly about something. But I mentioned Jay because Jay was a really clear example of how to work with a child around the different interventions that made sense for him in an age appropriate way, and also bringing Lola into the work. You know, Jay didn't know me, Jay needed to trust me. And it made sense as he was getting to know Lola, who was a family friend, but not well known to Jay before Dad died, to help incorporate her as really the main person who is going to be his constant and his mainstay. Subsequently, you know, down a couple of years after I was working with Jay, Lola wound up adopting Jay. So Jay actually and Lola became a tight family unit and a permanent one. It's important when we're working with children and families to look at what kind of family system they have, open versus closed. And why that's important is the family open to interventions? Are they open to new people? Are they open to letting help in? Or are they uncomfortable with that? Are they holding fast to other ways of doing things that aren't working necessarily? Are they resistant to help? Are they resistant to letting anyone in to help them? It's important to support strengths when we talk to families. There are opportunities for growth, opportunities for deep discussions, and also connecting. We want to always connect people with resources who are going through loss. You know, and I didn't talk at all really about teenagers. So developmentally speaking, from 11's not a teenager, but when you're looking at the stages again from Piaget, we're really talking about the formal operational period from adolescence to adulthood. And we were talking earlier about how children are trying to create their own identities. They're pushing back against adults. We talk about teenagers as trying to individuate, to separate themselves, to become their own person. And some teenagers find it really embarrassing to talk about their feelings openly. I don't know if you've experienced that. It doesn't mean they're not having feelings though. And we sometimes might misread a teen as not caring, as not feeling, just because they're not talking to us about death or talking to us about their concerns. So again, we try to look at behavior with them as well, but they do understand the irreversibility of death. You know, so I'm shifting a little bit. I'm sorry, I go back and forth. It's kind of my process here, but should children be at the bedside of a dying patient? That's the question I'm asking. I mean, I filled in the slide, but I'm curious what your experiences have been. If that's part of whatever setting you're working in, if children are commonly present. We're in a hospital setting. I'm an outpatient, Kim's an inpatient. You know, the hospital has certain rules in terms of when a kid can come to the bedside. So we don't see children routinely at bedside, but certainly if a parent wants a child at bedside and a child wants to come, we certainly should invite them to come. Every situation is certainly different. Every family system is different. We really want children, though, to be prepared, whether it's at home, if someone's in their home and dying, or whether or not someone's dying at bedside here in the hospital. We really want to make sure children understand what they're going to be seeing. The sights, the sounds, the smells of a hospital, the sights, the smells of a person who's dying in their bed. And really talk to them about physical changes they might see. You might see a parent who can't really communicate with them, or a parent who behaves in a funny way that might be alarming. So it's always important, if a child's going to be at the bedside of a dying parent or at a funeral or some type of ritual related to a death, to make sure there's another adult around or a caring person who can be with the child and either sit with them and comfort them or take them away from the situation if it becomes too emotionally overwhelming.
Oh, before this question,
Yeah.
and thank you. I just wanted to bring up, I know that was such a great case Peggy brought up, and I'm like imagining just how important play therapy is with the children. We talk about a lot too, but if anyone had any thoughts or reactions to Peggy's case, or anything she said after as well, like feel free to let us know. I know someone wrote information is empowering, so oh, okay. I think they just responded. So I was just asking what they meant by that. Do you mean sharing the information to the child? And they said yes.
Good.
And
Yeah.
yes, information is definitely empowering to a child, or even allowing the child if they want to know. Some children don't want to know. So
That's a really good point. You
yeah,
know, to always respect where someone's at.
right. Even these little munchkins we need to respect them too. And we know that information to anyone, even adults, can be so scary, especially to a child who might not know fully what's going on compared to an adult.
So the good thing then to add to that, Kim, is if a child says to us, I don't want to hear it, and either they're like running around or they're covering their ears or they're ducking away, is to remind them that that's okay, that when they are ready to hear it, we're ready to talk to them about it, or we're ready to, help them with it, that they don't have to be ready in this moment, that we're always, and when by we, I mean whoever the adults are always going to be available to help them when they are ready. And it's important, that autonomy, to be able to trust your own self, right? And to foster that in children. And leading into that, I asked this question: do children attend funerals in your experiences? Every culture is so different. Every family system is so different. And this is not by any means scientific, what I'm about to say, but anecdotally, I can tell you that people tend to say one of two things to me: either, oh no, why would they do that? Or, of course, they're at the funeral, they're at the wake, they had a special black outfit. It's really, people seem to have strong feelings about this. I don't think there's a right or wrong answer to it, but I do think it's part of the information sharing and sets the stage. And I'll tell you that, I'll go back to that in a second. Children who get to go to funerals, if they're able to handle the funeral, and every parent knows their own child on this, hopefully, the child is getting support from the community, and also seeing that this is how our family honors someone who dies, and this is our ritual. So it's also an introduction to what we do as a family in situations where we're grieving. So if children are kept away from funerals, and it's because someone just doesn't think that's appropriate for children to be a part of, they may be missing out on an important family ritual and customs, and connection. But we always say that, parents are the experts on their children. And when we work with parents, we're really trying to bolster their ability to help their children and support them where they're at too. Were you going to say something?
I just thank you for that. I just wanted to read some of the responses. It seems like a lot of people have responded that children do attend funerals. There were some great points. Sandra mentioned that sometimes sharing information, going back to your previous question, Peggy, is not done intentionally. And some cultures are so expressive or talkative, the children can easily get to know something is not right. Kind of what you shared earlier. They can read some in the room, something is not right. Maybe an adult or a parent's emotional. Like, kids are smart. They know, even if they don't know what exactly they know, they know that something's a little off. And someone else said, Christine's comment of, when you ask if children should be at the bedside of a dying patient, she mentioned quite a difficult one where they watched movies, people dying. When it comes to a loved one dying, it could have a negative impact. It's true. And she's had an experience with an adult child who witnessed her dad die. They were together in the hospital, and Christine let the child witness it and got mentally affected thereafter. So she comments that it really requires discernment.
Yes, discernment, judgment, assessment, and always making sure that there's backup people to support the child, because sometimes someone will have a reaction or something unexpected will happen at the bedside, either in a hospital or at home, that you couldn't prepare a child for, right? Everyone does their best. Thank you for sharing all of that with us. You know, my next slide, I just wanted to jump to, I mentioned Child Life earlier. I was looking this up just to see, this is a link. When we send the slides, you can actually click onto it and look at the International Organization for Child Life. These, if you don't know what Child Life is, they are specialists with advanced education around child development and play therapy and working with children in the setting of illness. So they typically work with children who are managing illnesses in their bodies and explaining, you know, how to prepare a child for a medical test, how to prepare a child for surgery or chemotherapy, and helping siblings. But then there's another component, and we lean very heavily on them here. We're lucky to have them. They help parents around parenting in the setting of illness. So if we're working with a family and the parents are really struggling with how to help their children and concerned about some of the things we were mentioning earlier, Child Life will often get involved to the extent of talking to parents, giving them educational information, supporting them, sometimes meeting children. So here in our hospital, if a parent is actually coming to end of life and a child has not been at the bedside, and they're coming for the first time to actually see the parent who's been hospitalized, but the parent is very ill, Child Life with another adult will meet the child or children and in an age-appropriate way, give information, provide support, help them really prepare for what they're going to see at the bedside. And they have models of IVs and hospital beds, and really sensitively prepare the family around how to help their children, and also make recommendations for bereavement support too, connecting to different agencies and camps. They're an invaluable resource. So if you're lucky enough to have them, you know, do reach out to them if you haven't. And if you don't think you have them in your setting or wherever you work, take a look at the website and see how you can access the information. It's really important. One of the challenges for all of us who do this work, especially if you're working with children and families, is that it's really overwhelming. It's easy to become engulfed in the trauma and the sadness. So, you know, it's really important to think about support for yourself, supporting each other, whether they're professional organizations like APGA that can provide a role in support. Some support comes from education, but also being able to talk to people about these challenging cases that we're all managing. And this little slide here talks about some resources for children who are grieving. In the United States, we have the Dougy Center, which is really helpful. And I apologize, I typed this slide, and I don't remember the names of these organizations, but they're international, and the bottom one you can see is Grief Share. It's in Cape Town. I don't know if anyone's ever looked into it. But when we send the slides, if you can look at these resources, they may have directions for you in terms of guiding the families that you work with too, or handouts that you give to people, or suggestions. Important, right? We have to keep reaching out. There is a psychologist named Dr. Gilbert Kleiman, and he argues for, and I'm going to read the slide, small doses of information about stressful topics such as death for the purpose of preparing children in advance for the certain reality of future exposure. So he did some work in the United States in schools and trying to help develop programs to teach and prepare children, just as the slide says, about such topics as death, that if we do this as part of the overall education and preparation, it really helps. You know, in the United States, all school systems are different, different culturally, different resource-wise. I don't really know that there are a lot of programs that are actually talking about death unless somebody has actually died. A lot of our programs tend to be reactive. And really, Dr. Kleiman is talking about is being proactive, right? Trying to anticipate. And I think it's a good point. And I mention it today for you to think about in terms of your own work, that the more prep we can do for people, they'll have more tools, certainly. And a little word about trauma. And I said this earlier, and I'm going to repeat it again. Kim and I and Dr. Diamond are not experts in war and the different atrocities that people are experiencing around the world. We're just not. Our lens is illness and death within the context of illness. So it's really important that, and I know this has come up a number of times, if you're dealing with people who are in the midst of war, you really need to talk to specialists about that specifically. So in preparation for today, we were looking at some websites, and the first one that we mentioned is Children in War. A lot of good information on these sites. I was actually really, what's the word? Impressed. I would be curious to know from any of you who are in these situations what you think, and whether these websites resonate or are helpful. ACT International actually had a conference apparently about a month or so ago on trauma. Take advantage of all these different websites, and the more you search, the more you find actually. UNICEF is a good one. I quoted that UNICEF statistic when we started talking earlier, and I think that they're a really important agency to look into in terms of resources. And that the one that I cited here actually cites the Ukraine. It's not touching wars in Uganda. It's not touching the war in Israel right now, but I'm sure they're updating, and it's again important to get resources that make sense, right? And training that makes sense. Does anyone have any questions or thoughts about anything that I said? I covered a lot of different pieces of information today. I think that the main takeaway is that certainly information is empowering, that when you're helping children who are grieving, you're actually helping the whole family. And that the reason, and I said this earlier, and I don't know that I got into too much depth on this, but what I meant when I said earlier that our goal is to help children stay on developmental track and make sure that they're meeting their milestones. We know that when someone experiences a significant loss, especially children losing a primary caregiver or parent, it could interfere with some of the tasks that they need to do, which is why if a child seems to be presenting with a worrisome behavior, we want to intervene and try to get them help, because we want to make sure that they're able to take care of their bodies, be able to go to school, be able to become functioning adults. And that's what I mean by milestones. We want to make sure that children move from childhood through adolescence to adulthood in a way that makes sense, and they're functioning adults in our greater society. And we intervene when we see things that we're worried about.
Just gonna read out 2 comments that came up.
Sure.
Someone wrote, in our culture, children are in most cases not included in talking about what might happen. The reality of the matter is often communicated with adults. So that is a tough culture. And sometimes we see it even here in New York, in the States, where really the children are almost kind of like shutted out or shunned out. I had someone who their loved one was dying, and the kids at home had no idea dad was in the hospital and dying. And the mom was like so protective of, oh, you know, we'll just tell them when dad dies, like it's gonna be okay. And I remember how difficult it was for me, because I was thinking if I was in the kid's shoes, I would want to know. But of course, we need to respect other people's cultures. You know, we don't want to be biased or judge people in a certain way because my culture is different from our patients' cultures. But we're gonna see.
Well, I guess so. My question then, and thank you so much for posting that, is what do you think of what we've been talking about today? If you're from a culture where this really seems to be a foreign idea, sharing information and including children, what do you think about what we're talking about today, and what will you do with it? Do you think what we're saying makes sense? Do you think it's isolated to people in the States? I'm curious if you could, if you're up to responding about that.
Another comment that came up, they were just acknowledging some families allow children to attend funerals, but some don't, as a culture, norms, and beliefs. But this person, Emmanuel, was saying, I think now it's very important to our community to change their attitude towards children. And we hope this session helped you, to encourage you at least, or be comfortable with trying to make those changes, or even acknowledging, you know, that this is hard. It's hard to work with children. I feel, even doing this work for almost 5 years, I still feel uncomfortable with children. But that does definitely, like, reviewing this, talking to support my own colleagues like Peggy, it helps to like brainstorm ideas or even different interventions that I can do when working with families and children, because we don't want to ignore them.
Well, let me add to that piece, Kim, too. I mean, experience is certainly helpful and important, but anyone who works with children should go for some extra training. And I don't know if APCA has any information about that, but I can certainly get you some information, some general information about where to look. I've had a lot of extra training in working with kids, including having done some child life work when I was in grad school, and also gone for extra training. And I periodically continue to go for training. And I think, to your point too, when we work with children, it's really helpful if you have a team of people to talk about cases with, and to continue to get training. And some of these ideas that you were talking about around ideas about not giving information, not being protective. When we meet families who feel so strongly about the protectiveness, it's a helpful idea perhaps to engage them around what that looks like. And maybe for some families, that's what they feel they can manage. It's a very out of control feeling to manage, to be a surviving parent or caregiver, and to be charged with raising children. You know, we were talking about this earlier, that it's a lifelong process to understand the death of an important person like a parent. So that's an enormous responsibility, very hard work. And one thing we know about, I was saying, you know, children age, so the whole family system does. So a parent may not be as equipped to talk to a 5-year-old, but they may handle adolescence a little bit easier. They get to know their children longer and longer. It's an evolving relationship and conversation. And if we could not pressure people, it's not going to, the grief doesn't get handled in a moment. It's a process that we continue to work through. And if we can encourage people that to keep working through it. And also supporting the fact that parents are trying to do their best by their children. And that's the tact I take. And, you know, I have a very strong, clearly in talking to you today, I have a bias that I think children should have information. But I also can talk to you from the parent side of things. It isn't so simple. And again, we have to support people in knowing who their children are. But if we can help people identify who their supports are too, I was talking earlier about children naming their helpers, but if parents can also identify who their helpers are too, sometimes another family member can step in where a surviving parent or caregiver just can't, and provide information or be there for support. We have a Q&A question.
Those children.
So there are a couple of questions. So Eunice writes, this information makes sense. Children are included. Our culture, giving age appropriate information and working with the family. If children are excluded, the children will get information from elsewhere. Yes. Which might not be the correct information. Today's children are very clever. I can tell you that a few years ago, I counseled a brother and sister. The sister was 8 and the brother was 11. And I was talking to them. Their mom had breast cancer and their mom wanted me to meet with them because they had some concerns and they were really bright kids. And one of the questions I was asking them was about how they understood mom had cancer. And the boy who was the 11-year-old said to me, I'm not understanding what you're trying to find out. Are you asking me, when did we know mom had cancer or when we were told? And I said, well, tell me about that. And the little boy said, well, we weren't told right away about mom. We knew something was wrong because dad was taking a lot of time off from work. So he was around the house a lot and we wouldn't see him during the day typically. And mom and dad were going behind closed doors and sometimes mom had a red face. So they had a plan. What they did was they sent the 7-year-old sister to sit near mom and dad when they'd have conversations. So she would sit as a decoy and color and not look like she was paying attention to their conversation. So she would pick up all kinds of information and bring it back to the brother. Eventually, the brother, the older kid, the 11-year-old, started to ask questions and the parents were able to give them information and they were actually coming to see someone else in my agency. But it was really stressful for them because the information that they had was wrong, but they knew they had to get it. How do you handle a child who's irritable for a longer duration after losing a loved one and does not trust any of the new guardians to provide for his or her needs? Who's irritable for a longer duration? What does that mean, a longer duration? I guess I'd want to know about that. I mean, just reading that statement, I mean, that just seems so painful. And it looks like the child has new people in his or her life taking care of them. I think that I would maybe see if the child would be open to play or drawing about their feelings. I think we need to know a little more information. I also think that depending upon the situation, the irritability may last a little bit. I think we need to know more information about that. So I don't know if the person who wrote the question, if they're able to ask the child about their feelings and if there's any way of getting them out. There was an activity we used to do called a feelings blanket. And it was this blanket that I would bring out with a group that I ran, and it had different objects in it that we would use as ways of dealing. So there was a pair of sneakers, and what do you do with sneakers? You can run out your energy. There was a pillow, you could pound it, you could cry into it, you could scream into a pillow. I don't know if that kind of an intervention would work, but obviously you're asking the question, so there's concern. I don't know if it makes sense also to bring the child to a medical professional just to make sure that the child is feeling okay. But I suspect time and keep talking to the child or playing with the child around their feelings. And if you want to respond in more depth about this, you could also email us. I'm going to share our email in a minute. But it's hard, right? Because if a child seems out of sorts, we are concerned. And I don't know if you have access to any bereavement services where you live. That probably would be helpful. And maybe even asking the child if they want to talk to other kids or be with other kids who are going through this. Well, it sounds like there's also just a lot of adjusting, right? I hope that was sort of helpful responding to you in that way, Anonymous, but you are welcome to email me in depth and we can talk more about this. And I want to add that this was our 4th session. What we're planning on doing December 1st is kind of having an open session, reviewing our last few sessions with everyone. And I don't know if the people who are in the audience today have participated in any of our previous seminars, but we were thinking we would provide an opportunity to actually discuss cases like this in more depth, either by chatting or if there's an ability that APCA has to unmute people. But we want you to think about if that would be helpful to you, having kind of an open session where these concerns can be attended to a little bit better and more thoroughly.
Yeah.
Anything you want to add about that, Kim?
No, I think we covered a lot today, and thank you for it's always so nice when everyone is so engaged and sharing their examples or things or even questions in their work or their own struggles. So we appreciate your openness and your vulnerability, since it's very helpful. Yes, someone wrote, this is my first seminar. This is a series we've been doing with APCA. This is our 4th session. We've been reviewing different topics each time. Like Peggy said, we're gonna not do an educational session next time, but rather we wanted to do like an open forum, an open space for you all to bring any examples or cases or just even stuff that we've been reviewing. You can definitely bring questions or thoughts ready, and we'd love to just speak with you in live time about how you're doing or how the work's going, or if you even need any advice or talking through or processing. Yes, like Dr. Diamond just wrote in the chat, the other past webinar sessions are recorded. I don't have the exact website, but I know it's on the APCA website and it's open to public, so you can view those at any time.
Yeah. I'm sorry our video didn't work in terms of seeing our faces. But it's really always lovely to be with you. It's great to have this opportunity, even though we're not in the same space. It's fascinating to us that people throughout the world are doing this work in so many different ways. And we know that many of you are working in really challenging, difficult situations, providing care to people and providing care to children and families. And you're amazing. And we also know that many of you are ending your workday. And we hope you have a very peaceful weekend. And we hope, let me actually move on. The last slide has our email addresses. Please don't hesitate to reach out to us. We've mentioned our email addresses every time we speak. If there's something that we didn't address properly, or you're confused about, or you want to share something, please don't hesitate to reach out to us. We will respond to you. The other thing is that, again, we're presenting this information from our vantage point and our expertise here in New York, our Western lens. Many of you are experts in your own settings. So we appreciate when you share information with us and with each other through the chats. Thank you for all the good work you do too.
Yeah. We hope to see you at the next session.
Yeah, so we believe the next session is December 1st.
I think we're also going to send a survey. I know some of you mentioned creating like a WhatsApp group or a place where we can all get together offline from this seminars, write an email group. I think someone mentioned. So I'm going to ask, we're going to send out a survey short in a few days or so, just asking what platform would be best for everyone. So please be on the lookout for that.
And if anyone looks at any of the information on the slides, if you've looked at any of the international links that we've put there, I'd be really interested in feedback on whether or not those agencies are helpful to you. Or if you have others, you know, in subsequent sessions that we're going to have, especially the December 1st one, if there's something that you have found that you think would be helpful to people who are participating in this, please don't hesitate to share it. As I said, we don't have the monopoly on information. And again, if there's something for December 1st that you want us to cover in more depth, since we did cover a bunch of things related to children and information giving and grief, please don't hesitate to ask for it.
Thank you all.
Yeah.
Have a good weekend.
Yes, it's 10 o'clock, so I guess we are going to stop for now, unless someone has anything else they want to say. Take good care.